All right, folks, it's 1 p.m., so I'm going to take us into the next item on our agenda. So thank you so much, everyone, for tuning into this panel as part of today's conference, where we're going to start taking a deeper dive into the next step of our journey, which is focused on recovery. So to provide a quick introduction, I am Kristina Brant, and I'm moderating today's panel on recovery. I'm an assistant professor of rural sociology here at Penn State, and I'm a faculty fellow with the Consortium. I'm a qualitative researcher and ethnographer, and my independent research focuses on how families navigate substance use disorder and recovery, and how rural communities kind of come to understand and respond to substance use and recovery. So my most recent independent project focused on families where relatives were raising kids due to parental substance use, focusing on the perspectives of both relatives and parents, and thinking about how institutions and bureaucratic processes that create these arrangements impact family dynamics. I'm in the early stages of a new project that's following parents as they leave substance use treatment to track how child placement arrangements impact parents' recovery processes. And here at Penn State, I'm also involved with Penn State Extension, where I work with the Relatives as Parents program to design and implement programming for relatives raising kids. So we have a great group of panelists here to answer any questions you all might have about the individual processes of recovery, the social and community dimensions of recovery, what organizations are doing to support recovery, and more. So I would love to introduce them real quick, and then I'll have them step in to give some more information about themselves and their work. So first, we're excited to have Dr. Bo Cleveland, who is a professor of human development and family studies here at Penn State. He leads the Recover Lab that focuses on recovery research, particularly thinking about how individual characteristics and individual social environments interact to impact their behavior regarding substance use and recovery. He and his lab are widely published in the field of recovery research, and they're pushing Penn State's activity in this field by building evidence-based interventions to help individuals with substance use disorder enter and sustain recovery. Second, we're welcoming Philip Rutherford, who's the Chief Operating Officer of Faces and Voices of Recovery. So Faces and Voices is an organization that seeks to utilize advocacy and education to help change the way recovery is understood and embraced, and to ensure that all people have the right and resources they need to recover. So Mr. Rutherford serves as the front lines in this work as a recovery coach, but as the COO of Faces and Voices, he also applies his background in corporate sales and marketing to propel the work of the organization and its mission. And he also serves on the standing committees of multiple federal agencies like NIH, and on the board of many other recovery organizations as well. And finally, we're glad to have Dr. Jason Whitney with us, who is the program coordinator of the Collegiate Recovery Community, and he's also an assistant teaching professor in the College of Education here at Penn State. The Collegiate Recovery Community is a program that supports students in recovery from substance use disorder and alcohol use disorder through multiple types of programming for students. And Dr. Whitney's work with the Collegiate Recovery Community has been recognized by the Association of Recovery and Higher Education as going above and beyond to support students in recovery. So our panelists' expertise and experience spans research and policy and practice regarding recovery. So I'm excited to hear their thoughts about your questions today. The panel is going to work exactly how our past panels have operated so far today, but for people who are just joining in, basically I'll invite our panelists to share a few words to introduce themselves and their work, specifically pertaining to understanding and supporting recovery. And then at that point, we'll dive into questions for them regarding either their work or recovery in general. So I invite you to please submit questions. You can either use the chat or the Q&A. They can be directed at an individual panelist or the whole panel in general, and I will relay those questions as they come in. So with that being said, I'm going to ask our panelists to kick this off with some words about themselves. And I'm going to pick on Bo because he was the first on the list of panelists for today.
All right. Well, thanks for picking on me first. Excuse me. My name is Bo Cleveland. I'm, as you said, I'm professor of human development and family studies. I'm SSRI co-fund and CSUA community fellow. So about 20 years ago, I had a chance to work at Texas Tech's Collegiate Recovery Community when I was a faculty member there. It's the largest collegiate recovery community in the country. I jumped on this chance because my father was a homeless addict, and I just wanted to learn more about this and try to contribute. I found it to be an amazing area, really interesting, methodologically challenging, and also potentially really, really important. My work at Texas Tech produced the first paper about collegiate recovery communities, as well as a book about the need for and how collegiate recovery communities function. This helped found collegiate recovery communities across the country. The people who were founding them were actually going from place to place, bringing our book. The collegiate recovery movement has gone from 5 collegiate recovery communities to over 150. So after coming to Penn State, even though my work was in another area of developmental behavior genetics, I was able to develop a collaboration with Penn State's Hershey Med School on the dynamics of interpersonal, social, and biological re-regulation during primary OUD treatment at the Cairn Rehab Facility in Pennsylvania. Both at Texas Tech and at Cairn use within-person smartphone-based data collections to capture the challenges encountered and strategies applied on a day-to-day basis to maintain well-being and recovery. The last few years, I've made recovery my primary research focus, and I'm currently focused on the daily life of people maintaining recovery linked to recovery houses and recovery communities. I'm working with 2 groups in Pennsylvania, the RAISE Project, which stands for Recovery, Advocacy, Service, and Empowerment, and that's in Harrisburg, Lancaster, and York. Also, Lost Dreams Awakening in New Kensington, Pennsylvania. And this work is aimed at trying to understand how recovery communities impact the daily lives of people who affiliate with them. It's funded by NIDA through a grant at the Recovery Research Institute at Mass General and Harvard. This project includes working closely with community members on the measurements that we are developing and data collection protocols that we use. So we take our measures to the community, they review these measures, they tell us what's right about them, what's wrong about them, and we change them. And also we get to eat a lot of food with community members because food is really important to developing friendships. So across these projects, we have about 70% compliance to 95% compliance with our surveys. This allows us to document difficult days and changes in risk when they occur. And they can also be used to predict post-treatment relapse. So I also get to serve on Pennsylvania's Department of Drug and Alcohol Programs Recovery Rising Policy Commission. And I think that to wrap up, I just want to say my goals right now as a researcher are to get members of the recovery community to the research table. I want to increase understanding of the heterogeneity of recovery processes and pathways, both as recovery is built and maintained, and understand the dynamic interrelationship between recovery and recovery capital that includes how individuals access recovery capital when they need it. And the ultimate goal is to develop tools that recovery community centers, recovery house programs, recovery specialists can use to characterize recovery well-being and program effectiveness. Thank you.
Thank you, Bo. I especially appreciated you sharing your personal connection at the beginning. I feel like that's so important when we're dealing with topics like this. And I'm excited to hear more about your community engaged research methods that sound really fascinating. So I'd love to pass it over to Philip for a short introduction, if you may do so.
Excellent. Hi, everyone. My name is Phil Rutherford, and I'm the Chief Operating Officer at Faces and Voices of Recovery. We're an advocacy organization focused on promoting the presence and prevalence of recovery supports. Now, I know I'm in a room with really smart people, but if there's anyone in here like me who needs stuff spelled out for them, what I mean when I say recovery support services is the involvement of people with lived experience in finding solutions to substance use disorder challenges. I'm a person living in long-term recovery, and it's very important to me. So at Faces and Voices, we do a few different things. In the policy space, we advocate for direct funding of recovery support services and community-based community-based organization infrastructure. A lot of services like mental health, traditional SUD treatment, and other social supports are driven by a fee-based model. And I'd say over the past 10 years or so, a number of states have begun to offer this model for recovery support, but a large number of organizations are still primarily grant funded. Unfortunately, as I'm sure many of you know, the world has already started to shift from fee-based to more of a managed care model, and some places are even exploring value-based care. So there's a lot of work left to be done on this front. Another thing that we do in the knowledge space is that we provide training to organizations around the country on best practices and other models of service. We educate on organizational development, sustainability, supervision, and just about anything else under the sun as it relates to recovery support services. We were founded in 2001, so we've been doing this for about 20 years, and we developed a knowledge base that we believe is useful. In the data realm, we curate a set of approximately 100,000 patient records focused specifically on recovery outcome data. We use evidence-based practices like the BART-10, the ARC, outcome rating scale, PHQ-9, GAD-7, that sort of thing. And we use those tools to give us insights about people engaged in the recovery practice. In the community space, we manage a trade group called ARCO, the Association of Recovery Community Organizations, which is a group of about 200 community-based organizations around the country. We also run a group called CAPRIS. We love our acronyms here, as every group does. And CAPRIS is the Council on Accreditation of Peer Recovery Support Services, which is it's an accreditation group, think CAR for JCO, but for peer recovery support services, and is focused on fidelity and rigor around recovery supports. But I think at the heart of everything that we do, it's all about we want to bring awareness and attention to the fact that yes, people that suffer from substance use disorder need treatment, but they also need long-term recovery supports. And there's plenty of evidence that a 30-day or even a 60 or 90-day engagement does not constitute what is needed for treating SUD. And I feel like I'm preaching now, so I'll quit while I'm ahead. That is all.
It was a good sermon, so thank you. I thank you for sharing all the comprehensive work that you all are doing at Faces and Voices. And I think it will be especially interesting to hear how you all have seen the landscape change over time, having been in this space for 2 decades now. And so thank you for sharing that history as well. So finally, I'm going to pass it over to Jason for a quick introduction.
Hey, Jason, you muted.
Jason, you're on. Yeah, sorry.
Thank you. Thanks so much, Kristina. I'm Jason Whitney, the program director of the Penn State Collegiate Recovery Community. And it's great to be here today. We support students in recovery from substance use disorders here at Penn State. We're located in Pascagoula Spiritual Center, and we have dedicated recovery housing in White Course apartments, and we provide a range of programming to support those students. And we've helped students be successful since we founded this program back in 2011. I'm also the faculty advisor for Lions for Recovery, a student organization dedicated to supporting students in recovery. I serve ex officio on Lions in Recovery, the Penn State CRC's affiliated alumni interest group. And I serve on the advisory board of the Association of Recovery in Higher Education, and I also do some consulting with ARHE, helping the Independence Blue Cross Foundation with this cycle of grant funding in which they're attempting to help foster the growth of collegiate recovery in the Philadelphia area. That's probably good enough for now. Oh, wait, one thing it's important to say when I was muted is that I'm a person in long-term recovery myself from severe substance use disorder and alcohol use disorder. Since I was a sophomore at the University of Colorado at Boulder back in 1991. So I celebrated 30 years in November 1st. And so I think that's an important detail as well. And the pathway that I've chosen is 12-step recovery. And I've been involved in various 12-step programs for these past 30 years.
Great. Thank you so much for sharing more about the programming here at Penn State and your own journey. So I invite folks starting now to start submitting your questions, the Q&A and chat. I will moderate them as they come through, but until that happens, we'll dive in with some questions that we have prepared. So to start off, I'd love for us to think a little bit more about how we define recovery. This is something that I think has evolved over time, and there are still a lot of misconceptions about. So I'm wondering if the panelists could speak a little bit about how you see recovery from substance use disorder, if you see it as defined and solely in terms of substance use, or if it extends to other areas of functioning as well. Oh, please kick us off.
So I want to invite everyone else on panel and everyone here to talk about this, but Jason and I wrote a paper about this, and it went through different recovery definitions that are used by different governments and different private organizations. And the general progress in the area is that recovery is being defined as much broader than abstinence itself. And to the extent that actually some of the newer versions of recovery leave out abstinence, which is a controversial issue. But that said, it's defined more holistically. And there are definitions, especially ones in Europe, in Britain and Scotland, for example, that actually talk about how it requires community engagement and citizenship. And that is also not without controversy, because it may leave out some people who are finding their own quieter, more individualistic path towards recovery. But in general, it is defined more holistically as related to something broadly thought of as well-being, psychological and personal well-being. And another aspect that has been added to it is it's thought to be not a place that you arrive at and you're there, but actually that it's dynamically maintained over time, and that it may take on different shapes in different social contexts.
Yeah, I'd also add that on sort of boots on the ground, there is a wide variation in how people define recovery, at least in practice. Obviously, there are certainly a number of groups that define it as abstinence-based, but more and more across the country, we are seeing people that look at it kind of as Bo described in a holistic way. One of the things that personally, and my pathway was 12-step as well. But over time, I've seen a lot of wisdom in SAMHSA came up with a model some time ago called the 8 Dimensions of Wellness, which look at emotional, physical, occupational, social, spiritual, intellectual, environmental, and financial. I did not have that memorized. I pulled it up and read it. But looking at wellness in those terms has actually been fairly useful to myself and plenty of people that I know in recovery. Abstinence, it happened to be my pathway, and there's plenty of good. I have plenty of good empirical evidence in my own life that was a good start. But I think conceptually, recovery is much broader than that. And I think to the extent that we simply look at a binary measure like that, like I mentioned, our data collection, that is a stat that we do not always collect. We don't always collect that. I'll tell you what we do collect. We collect stable housing. We collect job attainment, goal attainment, and things that are meaningful. We have an entire section on what is meaningful to the person that we're talking to, right? What are the things that are meaningful in their life? And that for us is the measure of recovery.
So to follow up on Phil's point about meaningfulness and housing, there is another concept which is really important. It's called recovery capital. And when I first started in this area, and I was working with kids in a college setting, and then realizing that there was a distance between myself and the students because of my own experiences with my father growing up in our own poverty, that these kids had, the college students, they were legitimately in recovery and they had legitimate addictions, but they had lots of support. And I hope that if I ever end up needing treatment and recovery, I hope I have that support, and I hope that my family members have that support. But that said, not everyone does, and it's very important for me as this part of my career to focus on how to understand people's pathways that don't have that much recovery capital, and how they try to build it. And I think that in a lot of ways, there's one model of recovery that talks about the building relationship between recovery and recovery capital over time. As one goes up, the other one builds the other one, and vice versa. And in a lot of ways, it's even beyond abstinence, moving beyond the concept. As Phil was talking about recovery, I think he was sliding into, and I think appropriately, into recovery capital, because in some ways it's so interconnected that how you, not the recovery capital you have, but also how you access it may actually be at the core of what recovery is. And so if you're not accessing your recovery capital, you may have abstinence, but you may not fully have a secure recovery, which is a debatable thing. And we'll see what happens now I said that, what happens if this whole conversation goes sideways.
I'd actually love to follow up on that. I was thinking of recovery capital as well as Philip was when Philip was talking. I was wondering if you could, for everyone here, spend a little more time explaining what recovery capital is, and maybe think about how we can go about making sure people have access to recovery capital, and not only making sure they have access to it, making sure people are able to mobilize it when needed.
Well, this is something
I think that would be a great.
I wish I looked this up ahead of time, because now I'm going to embarrass myself. But basically, recovery capital is drawn from the social capital literature, which is sociologically based. And it corresponds to the resources that you have, that just like capital itself, or resources that someone has, in a sociological sense, and a cultural capital sense, and these sorts of things. If you look at the work of Putnam in the social capital and cultural capital work in that domain, it draws upon those concepts and brings it over to the recovery world. And it has a lot to do with the physical resources you have, also with the interpersonal resources you have, and also with the intrapersonal resources you have. And those may or may not be the exact three domains, that they actually are used in terms of labeling those three different domains. But basically, if someone has a lot of recovery capital, they have family that support them. They may have insurance, appropriate insurance allows them to access high quality treatment. And then when they leave treatment, they may be able to go to someplace away from their old social network of users. And then if they develop a social network of non-users, that's a big part of their positive recovery capital, fellow abstainers, but also non-users and people who respect their recovery. Someone's education level is part of recovery capital, because it allows them to negotiate society and live a more stable life. So I think basically everything that supports recovery is recovery capital, but it's also something that if you have recovery and you're working a program, you're building those things and you are accessing those things. So it's a dynamic linkage between the person and those different resources, many of which are outside of the person, but some of them are actually internal. Coping skills, for example.
And I know Jason hasn't spoken, so I want to I'm not trying to overtalk, but there's a really good example of layman's explanation of recovery capital that I want to offer to the non-smart folk here like me. So I was talking to a fairly high-ranking policymaker about trying to get some legislation passed. Not that I was advocating directly for the legislation to get passed. I was just educating him. And what he said to me was, he's like, I don't understand what the problem is. I had an uncle who went to treatment and he got some counseling and he was just fine. I don't understand why these drug addicts can't do the same thing. And I said, well, tell me about your uncle. Tell me some stuff about him. He said, well, he was working and he went to a supervisor and he said, I need some help. And they got him right into a treatment program. And he came out and he went to his aftercare and he went to meetings. And his wife let him back in because she had put him out and everything was fine. And that understanding of what substance use disorder looks like, what the effects of it are, and how that person recovered that is a positive, that is a person with a high level of recovery capital, because that person had a job, they had a job to go back to, they got access to treatment right away, right? Their insurance plan offered them access to treatment. In some states without Medicaid expansion, you're just not getting the treatment. And in ones that you do, sometimes you're waiting a month. And then he had a place to come back to. So all of that stuff informed or assisted in the process of this person getting well, whereas someone without those things is facing a steeper challenge. That's all.
I think this really intersects with what Jason does, because Jason provides support and a safe place and a community and also mentoring in a college setting. And people are building their own personal recovery capital there. And so when they get out, they have more intact recovery, and they also have a degree. And then so they're able to basically take a meaningful job that has a future. A lot of people get out of treatment or get out of jail, and then they go into a setting where it's great if they can get a job at a fast food place, which is a lot less meaningful. And also you may not think there's a great future for you. And all you're trying to do is just white knuckle it and stay clean. And that's much harder, I would suspect.
Yeah, I mean, as far as you're absolutely right. I mean, social capital is an important. You have to sort of access the social capital that's around you. A lot of people have all sorts of wraparound support available to them, and it's just a matter of, in some cases, for our program, for instance, brings a lot of that care to the students so that they're fairly comfortably supported in every aspect of recovery that you can mention, and the education and the linkage to sort of a professional career is a huge part of that. Absolutely.
So in thinking about these kind of individual elements that can support people's journey in recovery, I wonder if you all can speak about some community-based efforts that can help provide these tools to folks. What are some efforts that you believe work well or have seen work well in your work or elsewhere? And what do you see as some of the barriers to the success of those types of efforts?
Well, I mean, you said community-based, that's kind of our jam. I mean, recovery community organizations are a significant part of they're a part of our constituency, but these are community-based organizations where people can receive recovery supports. And if you think of like a public health navigator, so someone needs public health support, they go to a public health navigator, and that navigator gets them to the other health supports that they need. That's kind of what recovery community organizations do. So the presence of them, like I mean, our mission is that we want one in every county in every state in America, right? That's That's our stated goal. We think that they're that important. And the presence of them, though, is not in place of treatment, right? SUD treatment is critically important. It's good for stabilization. It's very important. But and I'm sure you guys know the stat that, at 6 months of abstinence, there's some, I think it's 24%. I can't remember the exact numbers. This is based on David Best's work. But around 5 years, that number is 85%, right? So getting people from that 6 month period to the 5 month period that's kind of where the importance is, except all of our resources as a society are pushed, not all, most of our resources are pushed into that first 6 month period of recovery. What RCOs do is they can get help after that period. And so that's one of the answers that I have for community-based. The barrier to that is, in a shocking turn of events, funding. There's no funding, like I mentioned in my initial comments around fee-based care versus grant-based, value-based, managed care, all of that. There is not an infrastructure for this. Most of these places that exist around the country, I sometimes joke when I'm doing training on this, is I say the way that most RCOs start is a few community members are pissed off and they look in their bank account, they don't have any money, and they're like, let's go, right? That's usually the starting point, because they're not typically well funded. So that is the barrier, is that there's just not a lot of appetite for building infrastructure for community-based organizations of this type.
I did recently see, I was perusing grants as a tenure track faculty must do. And I came across a grant, I think it was through SAMHSA, that was specifically geared towards recovery community organizations. So I can kind of see the shift towards where agencies are starting to recognize the benefits that you were just talking about, but obviously there's a long way to go.
Yep. And can I say one more thing on that, and then I'll shut up. We appreciate grant funding. But if you think about how the community mental health system was built, and now a lot of it's being consumed by larger organizations, but grants are fine to start, but grants always end, right? And so the move to fee-based payments are critically important. Kind of, if you look along a 10 or 15-year continuum of development of organizations, those fee-based structures allow organizations to build infrastructure and sustainability for when grants run out, and for when the public appetite for funding these type of things run out. We're already seeing there was a time 2 years ago where the only headline you saw was about the opioid overdose crisis. We're already seeing less information about that. And this year, the overdose numbers will be higher than they've ever been. So those grants will run out. Using fee-based is good, but we're already seeing a move away from fee-based onto managed care. So it's important developmentally for these organizations, yes, to get grants, but also to get access to Medicaid funding, and then ultimately to get access to managed care. So again, I'm preaching. That's enough.
I'm going to field another question that has come through. If we can shift gears a little bit. Can you all speak to disparities that you all see in access to recovery resources, and how you all think about potentially addressing some of those disparities?
I can speak briefly, but Phil may want to speak to this as well. There are historic differences in the support across the African American community versus the non-African American community that are really important to address. And Pennsylvania in particular comes up quite a bit. So I've been working with a group in Pennsylvania, a commission, and one of the major issues that came up in the first year was the lack of support, buy-in, and access from the African American community for the African American community in terms of resources. And this is a major issue that the state is addressing, and there's this is also related to, I think, overlaps in a latent way with the battlegrounds, historical backgrounds between recovery and treatment, which not everyone knows about, but they exist. There's a historical sort of cross-fertilization of ideas between recovery grassroots organizations and professional treatment organizations. And then there seems to be a drifting across time of the resources into the treatment bucket. And this is something that people in the recovery community are quite concerned about.
I personally, the collegiate recovery has been has famously overwhelmingly white, reflecting the populations in many cases of the universities in which that host these programs. But I think that, as we mentioned, that education is an important part of social capital. And I think that more and more what we're going to see is collegiate recovery expanding much more broadly to help students at all sorts of universities, including universities that are not four-year universities, universities that are not predominantly white universities. I think we're seeing a little bit of that already in community colleges. And I think that more and more what we're seeing is students that are first-time college students who are achieving degrees with the help of collegiate recovery programs, students that probably would not have completed their degrees without the support of such a program. So I do think that sometimes even organizations that may not on their face look like they're serving well-served populations. Ultimately, the model, when scaled out, will support a variety of different individuals, and it'll help a lot of more people achieve education. And we'll have a generation of people that found that getting into recovery might have been the single greatest driver of success in every area of their life, including education and professional career and things like that. That recovery really is launching students. And we see it all the time, even at places like Texas Tech.
So what was the question? Are there disparities? Yes, there are disparities. That is a true statement. Just like in pretty much every other phase of healthcare, there are disparities, specifically in the Black, Indigenous, people of color group. And I'll offer just one or two statistics. The data on, I mentioned overdose deaths. Overdose deaths have largely leveled. There were more overdose deaths this year, but they have largely leveled out in the white population. In the Black, Indigenous, people of color population, in Blacks they have doubled. In Indigenous, is quintupled a thing. They've gone up dramatically. I think in Black women specifically, they're up 120%. So there are disparities. Rather than wallow in that, I think solutions for that it's just about being intentional, much like problems that we have with equity in this country everywhere. The solution is about intentionality and bringing intentional work to getting help to the specific community. And a lot of what that looks like is, well, for one thing, practitioners that look like the community, right? Like, so getting practitioners, so it's not just enough to say, hey, we're going to run a program in an African-American community, because that historically has not been very effective. But practitioners that look like the target community, programs that are developed and designed by people in the target community. And in the recovery space, it's no different. We look for that. I'm part of another group called Black Faces, Black Voices. We're not directly affiliated with Faces and Voices, but our focus is singularly driving resources into the Black community. And it is by recovery community organizations and other folks that are that are from the Black community. So it's efforts like that I think are at the heart of solutions.
Thank you for sharing that. I noted earlier that one of the things that stuck out to me in all of your introductions was this kind of focus on community engaged work and including people, including yourselves, people in recovery, in doing work around recovery. And I think, Phil, that you raise a really good point in that we can also look at this more granularly when trying to address disparities in access to recovery by race. That means including people of different races, people who are from marginalized backgrounds who are in recovery in the conversation. And I think that is often missed when we kind of paint a broad brushstroke about who is in recovery or who uses drugs. So we have a question that kind of returns to a theme that was discussed in panels earlier. Someone was curious if you could discuss any examples that you know of kind of quote unquote best practice faith-based recovery programs that are also open to using medication for opioid use disorder. So faith-based recovery organizations that are using more evidence-based practices.
So without calling them by name, I know of and so let's be clear, there's not 100 that I can just, there's not like a cohort that I can think of. I do know of a couple of programs in the Northeast, specifically Massachusetts and Maryland are the two states I'm thinking of, where there is a faith-based program that is friendly to MAT. But obviously, because the question was asked, we know that there is friction there. We know that there's sometimes, and not, I wouldn't even necessarily say friction. I think sometimes maybe just a lack of understanding or lack of embrace to that. And even the language of evidence base is not always conducive to the faith community. And which the fact of the matter is, specifically in the Black community, if you can't talk to faith-based, you're probably not getting very far, right? So I don't believe that to be. I believe that over the next 10 years we'll see more and more of that, because you can't save any souls if they're dead, right? So I think there's probably room for growth there, but I can only think of a couple, and I cannot tell you why they work and others don't. I can simply say that it's probably more about an awareness. I know that there's a colleague named Ayanna Jordan that has done a lot of work in this space, so I'll name drop her. So it is happening, but I would say it's a 1% or 2% phenomenon, not a 30 or 40%.
Just to add to that, it's fairly hard in general to really create a clear topography of all the different programs that exist and all the different stakeholders in a community. Because we're in State College, I was trying to find places in Altoona, and at first blush, we couldn't find any places, which, if you've been to Altoona, you would think that is unlikely. And Altoona is a hard-hit community and really struggles a lot with a lot of social issues. But then what we're trying to do now is basically go in there and really use sort of like a snowball sampling technique, find some organizations and then get referred to other organizations and other organizations. So, if you Google recovery organizations in any place, you get a lot of treatment responses back from Google and a lot of sites like that. And so a lot of recovery organizations are very much relatively quiet and don't have a big presence. And part of this is because they're small, part of this is because they're non-professional, and also because of the traditions of AA. And so for that reason, it's fairly difficult to do this work.
Yep, and I'll say one other thing, and again, I specifically around the Black community and possibly Indigenous as well. Historically, I had a good friend who unfortunately passed away, but one of his pet peeves was that he would go to a city and there would be a memorial for a number of people that had died of overdose. And there would be no, he was a Black man like myself, and there'd be a picture of overdose, a memorial for people that died of overdose, and there's not one Black face in the bunch. He'd go into a Black community, he'd hear about people that died of overdose, but there were no memorials, there were no services for those people. And his thing was, why is that? Why is it? And one of the things, and we did some surveying on this, one of the things we found is that in the Black community, sort of the admission of a loved one who used illegal substances, the criminality associated with it was producing kind of this sort of halo stigma effect, that it's not okay to talk about someone that's doing something illegal. Because of our problems with mass incarceration, and just, don't get me started on that, but because of the challenges associated with criminality, that it's not okay to talk about these things. So and I'm tying on to Bo's comment about these groups being hard to find. It's not as easy to advertise for your opioid recovery program that you're running for people that may or may not be still using opioids in your church basement, right? It's not as easy. Now the 12 steps have room for that, but programs that aren't that, it's just not the same in this community.
And I mean, another thing I would add to what you both have said, is that there are a limited number of successful models of recovery that have really ever worked. I mean, the 12-step recovery, it's a powerful technology, right? People, so you pick it up. There's a curriculum. It's communicated from person to person. It provides all sorts of social support. That support's ongoing. It's not uncommon for people to go to 2 or 3 meetings a week and engage at a level of community support that would be greater than really most people would engage with, even like a faith-based organization, for instance. And the principle of service makes it so that people come back even after they've achieved sustained recovery, and they come back and give that away. That model is really powerful. A lot of it's, somebody once said something like AA is a one-issue religion, right? And the issue is it's around not drinking if you make the admission of powerlessness over alcohol, right? I mean, so it's so essentially the abstinence-based idea is a powerful binding agent in that group. And we're just experiencing a lot of cultural shift. I mean, 12-step groups are definitely embracing, I think, MAT much more than they were 15 years ago. And I do think that people are understand absolutely the power of MAT for opioid use disorder, and the need for people to get on, for instance, Suboxone to initiate major lifestyle changes. And I think that you're finding more and more sort of people, especially young people on medication-assisted treatment, who are welcomed fairly openly into sort of 12-step, I don't know what you want to call it, peer support culture. But I'll say that there's always asterisks involved a little bit there. And just as there would be if, a friend of mine who's a social worker said, you don't ask a member of one like religious denomination to change their service because there's somebody from another religious denomination coming to that service, right? And yet 12-step recovery is constantly criticized for not changing up its approach in order to be more welcoming and inclusive of MAT. That said, MAT is 100% within a lot of the AA guidelines. I just think it's a matter of social support, and it's a matter of what keeps people coming to recovery and what sustains their interest in recovery and what keeps them around long term. And unfortunately, with medication-assisted treatment, there's just not a whole lot driving a long-term model there. Besides that, people could be on MAT for the rest of their lives. but there's not a lot culturally driving that model.
I am going to allow us to roll over 2 to 3 extra minutes so we can address our last question, the Q&A, and then we'll wrap up. So we've talked a little bit about doing community engaged work, both when it comes to research and programs. There's a huge push to do this that I've noticed in the work that we all do, but that can lead to, some ways of doing this that are more meaningful than others. And so someone was wondering if you could speak to some successful approaches to including members of impacted communities in programmatic and research work.
Maybe I should take a first shot at this. So when I started working with Texas Tech, it was in the same building that my office was in, the Collegiate Recovery Community. And I had lunch there every year for a year. And I just got to know everyone. And I became really good friends with the director. I got to know the students. When we were doing our surveys, we developed them with the students. So there was a very natural way of going about doing research with the community. And but it made me conscious that how important that was. And now it's a purposeful step that I take. And so I have discussions with the community ahead of time. I go have multiple meetings with the community. We discuss the constructs. We discuss whether the items are phrased correctly, and then just really sort of just embed yourself as much as possible. And I mean, just as an aside, this is something we should be doing with all of our research. It's just that it's more purposeful and a little bit more of a reach for recovery communities. But if I'm doing research in Cambodia, and I've done research in Cambodia, I work with Cambodians. So it's sort of bizarre not to do this. So now that said, most researchers are, people who haven't experienced what they research, and they've done a lot of reading about it. They know the theories. I suggest they go spend time with people and engage more fully with the populations of people that they research, regardless of what they're researching. Now, that said, the research in recovery is relatively new. It's only recently been a field. I started doing this before. I would send it to Addiction Journal, and they would say, "Yeah, no, this is not a thing." It branched off from mutual help support group and research. But as a field, it's really only been developed over the last 20 years. There's some research that goes back further, but not enough of it to cluster together to call it a field. And so because it's relatively new, there are more opportunities to face our ignorance and to sort of, get more engaged with the community. So I would just get back from a trip to Lancaster last week. And it was challenging, but I finally found someone to talk to me, and it was incredibly useful. The whole constructs that I was missing, so I think it's really important, regardless of what type of research you do, not just recovery research.
All right, so I want to give a warm thank you to our panelists. Thank you all for being here and for sharing your thoughts. Thanks everyone who is here virtually in attendance. I think we'll have time for about a 5-minute break, and then there's going to be a final panel on addressing stigma.
Thank you.
Thanks.
Thank you.